My name is Avi. I'm a psychology major at UC Berkeley.
That was me trying to read out what I type. I am a minimally speaking autistic and type to communicate. My brand of autism also comes with a bunch of comorbidities, behavioral and health challenges. At UC Berkeley, I'm a staff writer for the student newspaper, The Daily Californian. I'm very interested in research, so as a research assistant at the Henshaw Lab and now at the Berkeley Disability Makerspace Lab, I am also an undergraduate student instructor for a semester-long class on autism. Modern life is stressful even for neurotypical folks. With autism, we have all the typical stresses plus a lot more. For instance, there is continued non-inclusion by society. There is a constant judgment of your abilities, or rather the lack of them. There is continued gatekeeping by professionals based on their perceptions. Even programs meant for autistics may decide you are not the right fit for them. Education will last only 1/4 of our life. So there is worry about what happens in the post-education years and in our later years. We may be young adults now, but soon we will be middle-aged and then senior citizens with autism. We all need something meaningful to do with our lives. And currently we lack adequate coping skills to help us mentally cope with such issues. I have noticed a few common behaviors in my adult autistic friends and myself. One is acting out, or tantrums, possibly due to built-up frustration and lack of coping skills. We all need to have something meaningful to do with our lives. Others are in a state of resignation or apathy. I feel this apathy is mistaken for compliance or being very manageable by their caretakers. These are manifestations of depression along with suicide ideation. An autistic friend did in fact attempt suicide. In fact, a Yale study in the January 2018 issue of the Journal of Autism and Developmental Disorders pointed to the high rate of suicide ideation amongst high schoolers. Essentially, I feel that for many on the spectrum there is a lot of anxiety, depression, low self-esteem and internalized depression. As Professor Steve Henshaw pointed out in my developmental psychopathology class, there is a lot at stake. Medication has become the quick fix and the substitute for human support. There are, however, some issues. At an autism conference many years ago, I heard Stanford child psychiatrist, Dr. Antonio Harding, say that psych meds don't seem to work the same way in autistics when compared to the general population. So sometimes the maladaptive behaviors can worsen. In my psychology of sleep class at UC Berkeley, Professor Matt Worker mentioned that meds like sedative hypnotics essentially knock out your higher cortex. The result is non-restorative sleep as it lacks deep brain waves. Restorative sleep is very important in memory consolidation, emotion regulation and learning. In my cognition class, Professor Davina Chan remarked on how propanol is commonly used in ER to block memory in PTSD clients. Ironically, propanol is heavily used in autism to address behaviors as it supposedly has less side effects. Imagine trying to be productive and write exams when you are loaded up on drugs, which both block your memory and sedate you. Psych drugs have side effects too. I started getting involuntary cheek twitches after starting Risperdal. Increasingly, the National Institute of Mental Health is recommending the use of psychosocial therapies in place of drugs. I want to stress that mental health is a very real thing. Professor Marcia Saxton in my disabilities studies class defined mental health as the ability to cope with normal stress of life in order to reach his or her potential. We autistics lack coping skills. Ironically, there are many treatments and therapies available and routinely used in major hospitals in standalone diagnoses like depression, anxiety, stroke rehabilitation and PTSD. But when it comes to autism, mental health aspect is ignored. So we autistics lack access. A critical need for us in the mental health area is an acknowledgement that mental health is an issue, access to existing mental health therapies, coverage of these therapies by insurance, especially the state disability insurance like Medi-Cal, which many of us will be relying on in the future to cover our health needs. More experts and providers in this field. Now on to some of these cognitive treatments and therapies which are already available to other diagnoses. CBT, MATCH, DBT, ACT, MBSR. A lot of the material about these therapies is from my classes at UC Berkeley. Only a few highlights of these therapies are covered in this presentation. My immediate and incredulous thought when I heard about these in class was, why aren't these an automatic standard of care for autism? Somehow the label of autism seems to blanket many of our needs, which are brushed off as due to autism. CBT has been around since the 1960s. Professor Harvey mentioned that much of university-based research does not make it out into the real world unless they are immediate big money makers. So CBT only emerged in the 1980s for insomnia. It has been well studied since in the treatment of choice for depression, panic disorder and anxiety. The basic presumption of CBT is that thoughts and emotions influence our behaviors and vice versa. Ergo, changing our negative thinking will result in lesser anxiety. A primary tool in cognitive therapy is negative automatic thoughts. NAT is a train of automatic thought that we accept without questioning its validity. This often leads us into thinking traps and maladaptive behaviors. Examples of thinking traps are all or nothing thinking, catastrophizing, discounting positives, emotional reasoning, labeling, magnification or minimizing and mental filter, etc. CBT retrains the brain over time into rethinking situations so that you view them as less overwhelming, thereby reducing maladaptive responses. Again, the idea behind CBT is that thoughts and perceptions influence behavior. I had several years of CBT when I lived in the South Bay. I have not been able to locate a good provider in Berkeley yet. Here is an example of a CBT exercise. Every 20 minutes for 2 hours a day for 3 times a week, I had to write the following thought, feeling associated with the thought, the thinking trap. Then I had to reframe the thought in a more constructive light. MATCH is a version of CBT for children ages 5 to 15 with depression, anxiety, traumatic stress and conduct disorder. It is a parent training component to help support the child. It can be customized and allows for comorbidities. It also makes use of some appealing age-appropriate tools like the use of a feelings thermometer. Negative automatic thoughts are simply called blue thoughts. Blue thoughts are like sunglasses. They make the world seem darker, less clear and less bright. So the idea is to get the child to understand that your thoughts affect your feelings. Parents support child in finding blue thoughts, looking at evidence, and counter-thinking them into a more realistic true thought. DBT is dialectical behavior therapy. The core dialectic is to balance out the seemingly opposing ideas of acceptance and change towards the goal of a life worth living. A primary assumption is that the therapists can fail, the therapy itself can fail, but the clients never fail as they are doing their best. Commonly used for major depressive disorder and suicide prevention. It's a comprehensive support program done over 1 year with 24-hour support. Aspects include individual psychotherapy, skills training, phone coaching and a consultation team. The skills training portion includes mindfulness, distress tolerance, emotion regulation and interpersonal effectiveness. Mindfulness in DBT is an attempt to reach the wise mind, which is the intersection of the reasonable mind and emotional mind. You want to be mindful of your emotions. You observe and describe your emotion. Distress tolerance is learning that when you can't deal with triggers, you end up acting impulsively and may hurt yourself or others. You can reduce triggers through the TIP technique. T is to change your body temperature using cold water or ice. I is intense exercise. P is paced breathing. Breathe in for count of 5, hold, and breathe out for count of 7. P is progressive muscle relaxation. Tense muscles when breathing in and relax when breathing out. Difficulty with emotion regulation of intense emotions like anger and anxiety can lead to problematic behaviors. Emotions are expressed first as chemical changes, then show up in the body, face, gestures and outward actions. So you want to act opposite to these actions. Opposite face expression, opposite body posture, opposite action. The main thing about DBT is that it is both comprehensive and intensive with 24-hour support for crisis situations. When I was learning about DBT, I was thinking of how this would be an amazing support for families and autistics who have meltdowns, self-injurious behaviors and aggression. ACT is acceptance and commitment therapy. The basic premise is don't try to change your feelings. Change your relationship with your feelings. Accept your reactions and be present. Choose a valued direction. Take action. Mindfulness is living in the present moment. Diffusion is distancing from unwanted thoughts. You accept instead of avoid emotions. Lead a value-focused life. Values are now, goals are future. There is more. Honestly, when I first heard about ACT in class, I thought it sounded very much like Buddhist philosophy. Indeed, many of these techniques borrow from Eastern philosophy principles. Mindfulness-based stress reduction is the most popular stress reduction program used in hospitals across the country. Some examples are mountain meditation, where you visualize yourself slowly becoming a strong mountain that is strong, solid and grounded. Loving kindness is learning to love yourself by repeating, "May I be happy, may I abide in well-being, may I be secure, may I dwell in safety." It is used in treating anxiety, depression, substance abuse, eating disorders, sleep disorders, ADHD, and conduct disorder. Where is autism on this list? Neuroimaging from various studies of the techniques indicate neurophysiological benefits. Reduced activity in the amygdala, which is associated with fear, anxiety, worry. Increased activity in hippocampus associated with memory, cingulate cortex associated with emotion regulation, and temporal parietal junction associated with empathy. There is also greater hemispheric dominance. The left prefrontal cortex is associated with more optimism. The point. There are established treatments used widely for many other diagnoses. Somehow they are not considered for autism. We need to have them available and affordable to the autism community. They need to be part of our standard of care. I believe many of these techniques can be simplified and customized for the unique needs of each autistic. Our mental health matters too. There is indeed a lot at stake. A big thanks to Pramila Srinivasan for the opportunity to present at the Synchrony 2019 conference. Thank you, audience, for your patience in listening to an autistic point of view.